Hi everyone. This video will be useful for you to learn about cervical encerclage. Objectives. We will learn about introduction, definition, risk factors, mechanism, principle, indication, contraindication, and various techniques to correct to do the cervical encerclage procedure, namely McDonald techniques, Sirocco technique, and after that, nurses' responsibilities like patient care and monitoring and alternative treatments. First, introduction. Cervical encerclage is also called as cervical cerclage. Okay, it is a life-saving procedure and it is a surgical procedure done to prevent pregnancy loss in women who have a weak cervix. It was first described by Dr. Lash in 1950 as a life-saving intervention. Scientifically, the cervix acts like a strong gate at the lower end of the uterus. During pregnancy, this gate must remain tightly closed until term, that is, until 37 to 40 weeks. In some women, the cervix opens painlessly in the second trimester without contractions. This leads to miscarriage or preterm birth. According to obstetric research and guidelines by organizations like American College of Obstetrics and Gynecologists, cervical cerclage significantly reduces the risk of recurrent second trimester pregnancy loss in properly selected women. Okay, so according to American College of Obstetrics and Gynecologists, they say that cervical cerclage reduces. We can protect the pregnancy if the cervical cerclage is done during the second trimester for a selected women who have all the indications. So to explain this, think of the uterus as a house and the cervix as the main door lock. Okay, uterus as a house and the cervix as the main door lock. If the lock is weak, burglars like the pressure from the growing fetus can open early, right? So burglars can open it. Same way, cervical cerclage acts like adding a strong external lock to that main door. A 26-year-old woman with two previous painless second trimester losses at 20 weeks, presents at 12 weeks of pregnancy, ultrasound shows a short cervix. She is advised to cervical cerclage to prevent another loss. So this case scenario helps to identify the women who have the indication to perform cervical cerclage. Okay, she has already lost her two pregnancies during the second trimester because of the thin and short cervix. So she, in the third pregnancy, she comes to the OP at 12 weeks and she is advised for cervical cerclage to prevent this pregnancy loss. Okay. What is cervical incompetence? So I've been telling about the procedure that is cervical cerclage, that is surgical procedure in the previous slide. Okay, so what condition this procedure is done? The condition is called as the weak cervix is called as cervical incompetence. Okay, cervical incompetence is also called as cervical insufficiency. Is a condition where the cervix dilates prematurely without uterine contractions. Normally, cervical dilatation happens due to uterine contractions during labor. So it means when the mother is telling of pain, okay, during the labor, the mother will be complaining of pain. That is called as true labor pain when the cervix will get dilates. Okay, so that is cervical dilatation and effacement only happens during the uterine contractions. But when it happens in the second trimester without uterine contraction or without pain, then it is called a cervical incompetence. But here the dilatation happens silently. Okay, studies show women with untreated cervical insufficiency have a much higher risk of preterm birth. Okay, who did not undergo the treatment of cervical insufficiency, they will have a higher risk of preterm birth, sometimes up to 3 times higher than normal pregnancies. So scientifically, the cervix contains collagen fibers. Okay, it gives strength for the cervix. In incompetent cervix, this collagen remodeling occurs early, making it soft and weak. So because the reason may be because of hormonal changes and structural damage also can contribute. Okay, but there is some collagen remodeling occurring in the cervix, and also it occurs very early. Okay, the collagen which supposed to give strength to the cervix is losing its strength because of the remodeling. Okay, example, a woman at 18 weeks suddenly feels pelvic pressure and watery discharge. On examination, the cervix is 4 centimeter dilated without pain. This is a typical case of cervical incompetence. Risk factors. The common risk factors include previous second trimester loss, previous preterm delivery, prior cervical surgery like cone biopsy or LEEP. So LEEP means loop electrosurgical cauterization procedure. Okay, it uh, it helps to remove some tissues from the cervix, like when we are doing cone biopsy and you want to do cauterization and all. This procedure is done. It is just a daycare procedure. Okay, and they will just take it is a 10 to 20 minutes procedure and a minimally invasive procedure that uses a wire loop with the electric current to remove abnormal or precancerous cell from the cervical cervix. Okay, it is a daycare and it's performed under local anesthesia only. Okay, so it is a loop electrosurgical excision procedure. And the other risk factors like cervical trauma during previous delivery, congenital uterine anomalies, and early rupture of membranes. Scientific evidence shows that women with the previous cervical surgeries have reduced cervical length due to the removal of the tissues. And transvaginal ultrasound measurement of cervical length less than 25 mm before 24 weeks is considered a strong predictor of preterm birth. So this thing you have to remember is before 24 weeks, where the cervical length should not be less than 25 mm. Okay. Think like this: if a rubber band is cut repeatedly, it loses its elasticity, right? Similarly, cervical procedures weakens the cervical strength. Case scenario: a 30-year-old woman with a history of LEEP procedure, that is loop electrosurgical excision procedure for cervical dysplasia, presents with a cervical length of 20 mm at 16 weeks. She is at high risk and she may need cervical cerclage. So how the cervical cerclage works? The cerclage works by mechanically reinforcing the cervix. A strong, non-absorbable suture is placed around the cervix at the level of the internal os. This physically prevents early dilatation. It redistributes the weight of the growing fetus upward toward the uterus rather than downward towards the cervix. Research trials show that women in prior preterm birth and short cervix. Cervical cerclage reduces preterm birth before 35 weeks. So it is like tying a tight string around a cloth bag so that the content do not fall out. Same way cervical cerclage works. Okay. Principle. The principle of cerclage is the placement of non-absorbable encircling stitch at the level of internal os. It interferes with early opening and maintains uterine polarity. The normal pressure distribution throughout the uterus. The pressure will not be concentrated downward. The pressure will not be concentrated on the cervix. The pressure will be equally distributed to the upper part of the uterus like fundus. Okay. The suture remains until 36 to 37 weeks and it is removed before labor. Scientifically, the procedure reduces mechanical stress on the cervix and delays biochemical processes and leading to cervical ripening. So it prevents cervical ripening happening so early. Next, we'll move on to the indications. Cervical cerclage is indicated in During we have three types of indications. First is history indicated cerclage, next is ultrasound indicated cerclage, and physical examination indicated cerclage. In history, what must be the indication? The woman must have previous two or more than two second trimester losses. Then the woman is indicated for cervical cerclage in case of history. When you take ultrasound, the cervical length should be less than 25 mm before 24 weeks, as I said earlier. Then the woman is indicated for cervical cerclage under ultrasound. The third one is the physical examination indicated. Here, the painless dilatation. Usually, the cervix will not allow your finger. Okay, when you do a pervaginal examination, you cannot put your finger inside the cervical os. But when the cervix admits your finger without any pain, that is called painless dilatation during the second trimester, then you have to perform a emergency cerclage or rescue cerclage. Okay, then through the it is indicated under the physical examination. So these are the three types of indications. Evidence based guidelines support that ultrasound screening in high risk women is mandatory. Okay, case scenario: at 19 weeks a woman presents with a 2 centimeter dilatation but no contractions. Emergency cerclage or rescue cerclage is performed to prolong the pregnancy. We'll move on to the contraindications. Absolute contraindications include fetal anomaly incompatible with life, uterine infection, fetal demise, active labor, premature rupture of membranes. Relative contraindications include prolapsed membranes through the external os, and performing cerclage in an infection can worsen the sepsis and lead to maternal complications. So, you should not repair a leaking roof during a storm, right? During a heavy rain, you cannot repair a leaking roof. Similarly, cerclage should not be done during the active labor or infection. Principle. So here we already saw that when we are supposed to do and when we are supposed to remove. Okay, optimal window period is 12 to 14 weeks of pregnancy, that is the third month. Alternative timings is 2 weeks before the previous pregnancy loss. Okay, that is previously if the mother lost her pregnancy at 14 weeks, means in this pregnancy this cerclage procedure should ideally done 2 weeks before that, that is at 12 weeks. Okay, and removal, when we are supposed to remove the suture we done. Okay, when we are supposed to remove it, cervical cerclage is basically a suture. Okay, so when we should remove the suture is at 37 weeks ideally. But if the membrane rupture or if the pain begins, labor pain begins, then you have to remove the cervical cerclage suture. In emergency situations, when cervical changes have already begun, emergent cerclage becomes necessary. Future pregnancy will likely require the procedure as well. Early intervention provides the best outcome for maintaining pregnancy to the term. So we'll see about the McDonald's technique. Okay, so in McDonald's technique, the cervix is captured by a sponge holding forceps. Okay, these forceps will not injure the tissue. Okay, no Alice or no coccus or no artery forceps should be used. Okay, because those tips meant to injure or damage the tissues which they are holding, but this sponge holding will not damage the tissue. Okay, so Ian McDonald introduced this technique. It is the most common method. A purse string suture is placed around the cervix vaginally without bladder dissection. It is simple, less invasive, and takes less time. It is usually removed at 37 weeks. It is like tightening a string of a money pouch. Okay, McDonald's cerclage technique is similar to a money pouch. Okay, string around the money pouch. Okay, and we are tightening it around the os. Okay, at the level of internal os, the sutures are taken. It is started from one end, and many sutures are taken adjacent, and the same area is reached, and it is tied. Okay, And in this method, medically designed thread and needles are used, and the internal os is stitched together like a mouth of a closed purse or pouch. Okay. Internal os means it's nothing but the junction of the uterus and cervix. Okay. At that level only this McDonald circulates, or at that level only this suture is done. Okay. So as you see in the picture, um, dilated cervical canal and narrow cervical canal. In dilated cervical canal, the suture is taken but it is not tied, but so you can see the opening there. Okay. But after taking the knot, the os is closed. Okay. So after procedure, the os of the cervical canal is closed. Next is a Cervical Encerclage technique. So in this method, it is here also a medically designed thread, means umbilical cotton tape, okay, or proline, okay, thick thread. Basically, a thick suture material is used, okay, and it is used at the internal os, and it is stitched. Okay, V. and Shirodkar developed this technique. It involves dissecting the bladder upwards. Okay, first we will put an incision. Okay, and as you see in the picture A shows the incision. Okay, the place where the incision is done, and the tissue above that incision is deflected above. Okay, so those are the tissues of bladder. We have the bladder in front of the uterus, right? So bladder is dissected by doing an incision. After that, and placing a suture close to the internal os under the mucosa, and it provides strong support, but technically it is more difficult. Okay, so basically this involves lithotomy position of the mother, anterior incision and bladder reflection, posterior incision, placement of the non-absorbable suture like mercilin, and closure. So this method is preferred in women with very short cervix. Okay, so that is what given here. 4-step procedure. Patient is proceeded in a lithotomy. Transverse incision is made anteriorly and the bladder is pushed up, and vertical incision posteriorly it is done. A non-absorbable suture. Number 4, Braden is very thick. Okay, nylon or mercilin dacron. It's passed submucosally because we are doing the incision, and below the incision only we are taking the suture. So it is the suture is at submucosal level to the internal os, and suture ends are tied posteriorly with a reef knot. Incision repaired with chromic catgut. The other techniques like McDonald's and Shirodkar techniques or Hefner technique, abdominal and lash cerclage for specific clinical situations. Abdominal cerclage is done via laparotomy or laparoscopy, and it is useful for women with extremely short and absent cervix. Okay. We will move on to the pre-procedure care. Before cerclage, what you have to do is you have to take a complete history. You have to do a transvaginal ultrasound, rule out any infection, and keep the patient for NPO after midnight. Avoid any intercourse for 24 hours or before. And nurses play a vital role in psychological preparation. And anxiety is very common in these mothers. Okay. Immediate or after care. After the procedure, we have to observe for contraction, monitor the fetal heart rate, give bed rest for 2 to 3 days, administer tocolytic agents like isoxsuprine to relax the uterus and to prolong the pregnancy, monitor for fever, monitor for bleeding, or monitor if there is any rupture of membranes. Okay, I can give a case scenario. Like after a cerclage, a woman develops mild contractions. Okay, and mild contractions means she will complain of pain, and tocolytics will be given. Okay, tocolytics like isoxsuprine will be given to and to subside the contraction. The pregnancy is continued until 36 weeks. So this is a case scenario for an immediate aftercare of patient undergone cervical cerclage. Warning signs. Instruct the patient to report if there is any uterine contraction, if there is any vaginal bleeding, fever above 100 °F, leaking fluid, foul discharge, severe abdominal pain. So all these warning signs should be educated to the patient, and she has to tell you if at all any of these signs or symptoms exist. Early detection will always prevent complications. Potential complications are anesthesia risks, preterm labor, rupture of membranes, infection like a chorioamnionitis, cervical dystocia if the stitch is not removed, and cervical or bladder injury. These are some of the potential complications. So alternative evidence, in potential complications, evidence shows that complications rate is low when it is done by experienced obstetrician. Okay, if the knot is not, if a tight knot is not untied at the right time, it can tear the cloth, right? Similarly, if the cerclage is not removed at right time, it can tear the cervix itself, and that results in a big disaster. We cannot save the patient in that case. So it has to be removed at the right time. Alternative treatments are bed rest, and it reduces cervical pressure, and tocolytic agents can be administered to delay the labor, and antibiotics can be given to treat any infections causing preterm labor. So cervical cerclage is an evidence-based life-saving procedure for women with a cervical insufficiency. Proper patient selection, timely intervention, skilled surgical technique and good nursing care improves pregnancy outcome significantly. As nurses, your role in monitoring, counseling and early identification of complication is crucial in ensuring safe motherhood. Okay, thank you all.